Lovely. Welcome, everybody. Very excited to see so many people have joined the webinar this afternoon. Eva, if you could just stop sharing, that would be great. Lovely. So welcome. My name is Serena Lucensky, and I'm a clinical associate professor here at UCL, and I'm co-director of the UCL Online Master of Public Health. This webinar series is going to be part of the Public Health Voices webinar series. It's open to everybody, students, staff, and members of the general public. And it's really about showcasing the importance of interdisciplinarity in public health research and training. So this is the fourth Public Health Voices event of this academic year. And we've got a very exciting group of expert panelists who are going to be exploring the issues of intersectionality and gendered approaches to inclusion health services, research, and advocacy. Before I introduce you to the panel and before we kick off, I'd just like to maybe mention and sort of define what inclusion health is, and we'll be talking a little bit more about this shortly. But just to bring everybody up on the same page. So it's really an approach which is focusing on addressing inequities faced by people who are socially excluded. And these people might face typically lots of different overlapping risk factors for poor health. So issues such as poverty, violence, and complex trauma. So we're usually talking about groups such as those experiencing homelessness, sex workers, people who use drugs or are in contact with the criminal justice system, people who might be excluded because of their ethnicity or identity, such as Gypsy, Roma, traveler communities, victims of modern slavery, vulnerable migrants, and many other groups. So that's sort of the population that we're talking about. And in this talk, we're going to be talking about what is intersectionality. So this is a concept that was first described by a Black feminist scholar in the US called Kimberly Crenshaw. And it's basically to describe the fact that multiple forms of inequity often interact and compound one another. And so we see this a lot in inclusion health, where a lot of the groups that I've just described are overlapping, and this leads to further exclusion and poorer outcomes. But we also see that these factors can overlap with other issues around equity. So issues such as gender, which we're going to be talking about today, race, sexuality, disability. And this can really amplify, say, the consequences of experiencing homelessness or being a sex worker. So we're going to be talking about all these different issues, as I mentioned, from a service, research, and advocacy perspective. And I'd like to now invite our panelists. Each panelist is going to spend about 5 minutes introducing themselves and to talk about their work in inclusion health. And why intersectionality is important to the work that they do. So first up, we've got Binta Sultan, who was the first consultant in inclusion health in the NHS. She's currently based at Mortimer Market Centre and is inclusion health lead within the trust CNWL. Binta does lots of things. You will have seen her bio, I'm sure, when you signed up to the event, and she's going to talk a little bit more about the fantastic work that she does. So over to you, Binta.
Thanks, Serena. I'm just going to pull up my slide. Just check that you can see that.
Looks great.
Okay. Well, thank you. Thank you to Serena and to the UCL team for inviting me. It's a real privilege to be here and to be on the panel with Kate and Grace, who are amazing, and I know it will be a great discussion. So I'm a consultant in inclusion health, which is my main role. And I work currently in London and work around leading various programs of outreach for inclusion health populations across London, with working with people with lived experience as a core part of our team. I have lots of other roles, but what I take into all of those other roles is the inclusion health perspective. And one of the kind of key questions I was asked in terms of introducing myself is why intersectionality was important. So from my perspective as a brown, cisgendered Muslim woman, my experiences and the communities I'm part of and the socio kind of political perspectives I have, I didn't necessarily see reflected in some of the services that I was working with, including inclusion health services. And I found that quite jarring, and it made me just question and understand things, try to understand things a little bit better. So just briefly about inclusion health, as Serena's described what inclusion health is, it's relatively recently been defined, but it's centuries old concept, thinking about the health of marginalized populations, and it's characterized by this experience of extreme health inequity and complex overlapping needs. And Serena talked about some of the populations who are kind of considered part of inclusion health groups, and these groups have been defined in the National Inclusion Health Framework, which has recently been published. And so there's an awareness, more of an awareness of inclusion health groups, but I think there's a less awareness about intersectionality, and that racialized, gender and sexual minorities are disproportionately represented in inclusion health groups. For example, a third of people who experience homelessness are from racially minoritized populations. A fifth of youth who experience homelessness are from LGBT communities, and 70% of them report that their identity led to abuse and homelessness. And this is a graph from Serena and Rob's paper, which was sort of a seminal paper in inclusion health. And it really highlights the higher mortality for women among inclusion health groups, which is the reverse of the general population. And what I found difficult to understand is we weren't seeing women in our inclusion health services. We weren't seeing them in housing services. And then we're not being captured in those data sets. But we know that, so this report was published a couple of years ago and it's been recently updated, but this is a really powerful piece of research that was undertaken to really understand the impact of gender on disadvantage and experience of disadvantage. So of the people who experience all four domains of disadvantage of homelessness, interpersonal violence, substance use and mental health issues, 70% are women. But we weren't seeing them in our services, and we should have been, because these are services for the most marginalized populations. And as well as I was trying to understand why services were not seeing them, and it comes back to thinking about policy and who designs policy and what is said in policy and strategy. So in the National Inclusion Health Framework, which is the first framework that we have for inclusion health, they don't talk about race or gender identity. Women are only mentioned 4 times. They don't talk about sexual or physical violence or maternity care. And so if it's not there, then it's not going to translate down into services and prioritizing them. And this lack of representation of women, and particularly when I was through the pandemic, we saw the Everyone In programme, which highlighted the dissonance between what was known and what was the reality in terms of data, because it was an opportunity for everyone to try and access accommodation, and it kind of completely changed our perspective and our data on the diversity of people who experience homelessness. And one of the key things that came out for me was that women consistently weren't being captured in the data sets. And it led to several years of me and other people shouting that we needed to do something about this. And 2 years ago, it led to the GLA rough sleeping team bringing together a working group, which then led to the first rough sleeping women census in 2022, and then the second census happened last year. And so this is a gender-informed census trying to identify women who are rough sleeping. And we know that women who rough sleep do so in a different way to men because of safety issues. They won't stay in the same place. They won't necessarily sleep at night. They'll be on buses or in the McDonald's, or so they're not necessarily captured in data. So this census was specifically trying to identify those women in a different way to the traditional methods that have been used. And the second report was presented yesterday, and it shows that 9 times the number of women were identified through these gender-informed methods than through traditional methods. And it shows that we can do things differently, and it's provided the evidence that we need to do things differently and to fund the services for these groups who haven't traditionally been captured in our data sets. So I'm going to stop there.
Lovely. Thanks so much, Binta, for that great overview. An incredible statistics, 9 times as many women were counted. That's really, really incredible. I think we often hear about these statistics of, around homelessness, 70% are male. And I always felt that that was absolutely wrong. And it's great to have the evidence around that. So thank you. Next up, we've got Kate Luxion, who's also a researcher at UCL. Kate is a public health professional, social scientist, and conceptual artist, which I didn't know. I'm interested to hear about that, who works within the space of sexual and reproductive health. I'll pass over to you now, Kate, to introduce your research.
Sure. Thank you for having me. I'm really looking forward to this conversation with this group. So I thought I'd kind of start with the theory side of stuff. Being able to look and see why what Binta was just talking about is really important in terms of if we don't know whether or not people are there, we can't kind of measure what's happening to them. And so for a lot of the research that I do, it's an underpinning of both an intersectional approach, using the minority stress model. So who are these groups of people, especially within inclusion health, that have been minoritized through the ways in which things have been structured. And so having a gendered lens is extremely important, as well as thinking about all of these other facets of a person's identity and lived experiences and the ways in which they have to consider every single space that they're in. And so it's really important to remember that we can't kind of take and pluck single petals from a flower. You have to consider the flower as a whole in the same way that you can kind of consider the person. And we can see beyond just minority stress theory, but in the literature specifically, that it's important to consider the fact that previously there's a lot of attention paid to the responsibility for individual behaviors, but what we're finding scientifically is it's not that, it's whether or not the systems are in place to include those people, to allow them to have services, and that is more the responsibility of the disparities that are being seen. And so being able to see kind of not just the general stressors that everybody is facing on the planet, but also these additional levels of stress that people are facing that then lead to those poor outcomes and the ways in which it's present kind of biopsychosocially from the standpoint of both mental health and physical health. And an example I wanted to talk through based off of the research that I do, which is in reproductive health space, is what happens when we don't take an intersectional approach. We're kind of looking at 3 fairly fictional characters, but who do fit the role of the type of participants that you see coming into reproductive health research, that if we weren't to take a gendered lens, we would kind of miss altogether, either from an assumption in the process or just because we wouldn't be having thorough and complete data. So we might see then, if we don't take measures of race, for example, we know from the literature that Black women face much more in terms of stigma and dismissal of pain, as well as lack of recognition of communication that turns into poor health outcomes within maternity spaces. And so if we kind of go, oh, well, what's the general consensus of what women are facing within maternity care, completely overlook higher rates of mortality, poor outcomes for both the mothers and their infants. And then if we were to say, okay, well, let's look at a cisgender intersex woman who is assigned male at birth, does not consider themselves trans, if they're asked only their sex as part of this thing, they would become excluded from certain services. They'd have difficulties accessing certain things. There would be additional stigma that's kind of faced in that regard, as well as avenues of support that need to be offered to them that aren't being in that way. And then this third participant is somebody who does exist, even though it seems to be a fairly contentious discussion, especially currently within the UK, in terms of non-binary people, trans people who are giving birth, who are accessing these services, who are in need of contraception, who are in need of other forms of reproductive health care, and being able to access those in a way that's safe and inclusive and takes into consideration the fact that these services are needed to begin with. And the intersectionality side of it really is to highlight the fact that even if we have overlapping characteristics between these various people, that there's a unique experience for each of those three. There's going to be a unique set of barriers, there's going to be a unique set of needs. And so from a standpoint of approaching things both in research and in care as patient-centered and evidence-based is where that intersectional framework is extremely important to take into consideration and to apply. Because if you don't have that from the get-go, either within data administration or within the research methodologies that you're choosing, you inadvertently perpetuate the difficulties that people are facing because you're not making those services available. You're not allowing for them to be actually cared for. It's an inadvertent in most cases, but it technically is kind of a way in which the system goes against the adage of do no harm within medical spaces, and really making sure that taking that intersectional approach makes a point of stepping away from that and looking at who's actually accessing services. And it's better too from a commissioning and admin standpoint as well.
Fabulous. Thank you so much, Kate. I've got actually so many questions around that, which I'm going to save for the discussion so that we can get to Grace's introduction as well. But it's a really helpful illustrative example actually to see, you know, how these very sort of basic questions can lead to very sort of different, you know, data around on people's experiences. So that's really helpful. Fabulous. So last but not least, I'd like to introduce you all to Grace Sumner. Grace works specifically in women's homeless health, partially inspired by her own experiences of lived experience of homelessness and sex work. And she was the formal national lead for homeless and street-based sex workers at National Ugly Mugs. And now she's set up this wonderful Women's Inclusion Health Collective, which I think she's going to tell us a lot about as well. So over to you, Grace.
Hello, yes, I'm a bit of an unusual one. I'm not just going to have slides, but I sit with both hats sometimes. So I sit in professional meetings in professional capacities, but also have my own experiences of being a sex worker and drug user and being homeless. And I suppose one of the reasons I find intersectionality so important is because I found it was lacking. So one of the reasons I just got so angry and decided to start the Women's Inclusion Health Collective was because I thought exactly this, gender and intersectionality was missing. So we found in the Everyone In census that 21% of female rough sleepers were Black women. And, you know, Binta informed me that we only got that statistic because of the Everyone In data capture, but before then it wasn't recorded. And I thought that was absolutely shocking. And the experiences of Black women on the street will be completely different to my experiences. And they experienced multiple forms of violence. And there was recent research that found that Black rough sleepers were twice more likely to be arrested. And I think when we consider intersectionality, I think people see homelessness as like homogenous, or like sex workers as homogenous, and actually there's multiple factors such as immigration status that may prevent people coming forward. My specific interest is my frustration of services, and particularly the lack of inclusion of rape and sexual and domestic violence. It's just really not tackled in inclusion health, despite the fact that it's the most common factor. So it was found that roughly 90% of female rough sleepers have experienced some form of violence. 66% of asylum-seeking women have experienced gender-based violence. It's estimated 75 to 80% of Gypsy, Roma and traveller community have experienced sexual and domestic violence. And in any 1 year, 65% of sex workers report experiencing violence at work and are 12 times more likely to be murdered than women their own age. And I find we often fuel this cycle by not addressing it. So, for example, 850,000 women, mothers in the UK said that they didn't feel they had somewhere safe to stay. So this was a report by Shelter, and 69% of women therefore stayed in relationships where they felt unsafe because they feared homelessness. And I think if we're going to focus on are we perpetuating the system because we see homelessness through the very traditional lens of a single white man, British man with no children, and then as a result there's research gaps which ends up resulting in commissioning of services that do not meet the needs of such. And I'm particularly interested in youth and LGBT homeless as well, which is what I trained in. And it makes me laugh because it was so relevant to what Kate said. So I was born intersex, assigned male at birth, raised female, and you're right, I've never fit in any category. Capturing, I understand actually that one of the gaps in data capture is that we do not know if somebody is homeless and transgender, which, you know, I mean, I can sit here and rant all day about gaps, but I'll leave it short and sweet there because I know we have a lot to go through. But oh, sorry, actually, no, I want to quickly add, it's 20% of drug users are considered women, but even when presented with the same opportunities, they do not access drug consumption rooms globally. They still consume drugs on the street, and 49% of women in Camden said that that they had accommodation, but they left it for risk of violence. And this was something that was recently come out in the homeless women census, that actually the majority of female Russell leavers did have accommodation, but they were forced to leave for various reasons, and then it was considered that they had deliberately made themselves homeless and therefore couldn't access housing. I'll leave you at my anger and frustration there. So
I share your anger and frustration, Grace, especially around those intentional homelessness policies, which are you know, so damaging for women. Lovely. Can I bring Binta and Kate back as well? So thank you all for that brilliant introduction. I hope I see some, you know, questions already. Just to mention as well that we'll come to questions at the end, and you can click on the link in the chat to access the Slido and to put questions into there, and we can take those at the end. But to kick off, and I think this is a useful question to sort of everybody, and I don't know who wants to take it first. Why do you think a gendered lens isn't adopted in the work that you do? And maybe I'll come to Binta maybe first. Why is it not in the national framework?
Grace and I are smiling because we've talked a lot about this, had a lot of conversations about this, and it's frustrating. I think part of the reason is representation and whose voice is heard loudest in those spaces. And I don't think it's intentional, but I think if you're not intentional in who you include, then you fall into those patterns of the easiest thing to do and replicating those systems. And I think that is a huge part of the problem. I don't think we are inclusive enough in Inclusion Health, and I don't think that everyone's voice is necessarily heard. Grace and Kate, I'm sure, will have lots to say as well.
Yeah, I mean, just to kind of piggyback off of that, especially as somebody who does research in reproductive health spaces, the assumptions that are made around sexual orientation and gender have that kind of false idea of, well, everybody is going to be this, so we don't need to ask about it. But then that's exactly the way in which you don't have the data, because you're not even asking. And it's better to be able to show, okay, 1.5%, 2%, 3%, maybe 45%, because we know that there's more gender and sexual orientation diversity in younger generations, and as more data is collected. But you don't know that unless you ask. And there's not harm, it's not a threat to anybody to be asked this, but it's being able to say, are we even asking that question? That doesn't necessarily come up to people if they've not been put in a position to go, oh, there's diversity in this space, because they already fit in all the boxes that are available. And so it causes there, to be a limitation then in what's there and how things are looked at administratively, which makes it slow to change, because there's not a willingness to counter the fact that it's not whether or not people are there, it's whether or not people are counted, because they are there. That's not a question about that.
For me, I thought of this from multiple angles. And going back to what Binta said, who writes this policy? So, for example, during the pandemic, there was a report written by disengage during the COVID-19 who should get the vaccines. They completely missed off sex workers entirely as an inclusion health group. And I was like, yes, that's because you probably didn't run it past us. And similar to the slide that Binta put up regarding the inclusion health framework, it was me and Binta in a group chat looking at this framework they've not even mentioned the word women. They've not mentioned what on earth? And I think it's partially, I also think it's societal norms that people do not value women in the same ways. And I think some of the topics around women in inclusion health are really, really challenging. So child removal, sometimes police violence against sex workers, rape and sexual or domestic violence. And I think people actually just find these topics too difficult. And I've had professionals say to me, the reason we don't like to discuss sex workers is because we don't know how to have the conversation. And I've been told by professionals that, they prefer working with men over women because they find women manipulative and demanding, and and you got to remember that societies, it works. These healthcare systems are made up of people in society who have these values and views and don't, and I think that's part of the problem why we don't take a gendered lens, is because have we considered it, and is it too difficult to challenge? And when I started the Inclusion Health Collective, actually professionals said to me, oh, that's very brave of you to do, because all the women's issues are much harder to deal with. And I thought that's probably why we're here, because people have these attitudes. So that's my 2 piece.
So then, I mean, I think, and I think you all touched on this, and I've certainly seen it in my own research as well. What do we do when the data are lacking? I think this is a huge problem. I just finished an analysis of all people experiencing homelessness for all hospitals in all of England. But I only have data that categorizes people as male or female. 100% completion, no missing data. And yet, this is the binary sort of categorization that I've got to work with. What do we do when we don't have the data? Maybe I'm going to come to you first, Kate, because I think you've been thinking about this.
I mean, it's the kind of thing to where it's sort of being able to it's very difficult for me to separate advocacy from research, because it's exactly situations like this. And being able to say, okay, look, this is the data that we have. We need to make a point that we cannot make really strong decisions, that when it comes to the policy side of stuff, it's not going to be inclusive policy because we don't have an understanding of how this is. It's extremely likely, and one of the things that is not often considered, is that somebody who goes, okay, I have to choose sex, that whether a person is cisgender or transgender and they're a woman, they're going to choose female, which that's completely fine. But it's lost then that nuance in there because you're not asking the gender question. And by doing that, it completely then looks at it from the standpoint of, if we rely solely on sex, then it just completely misses everything. Plus, it's a whole other thing about a spectrum, not a binary, which I think we're all in agreement on. But it's just, you have to make sure that you're being very clear about the conclusions that are being made, that it's kind of like a strange categorical variable that is not as going to capture things as well as, say, like a group of 30 to 45 years old. You can say this is kind of what's happening, but you're not going to be able to say, well, this is what's happening to a 34-year-old, right? It's in the same kind of sense. If you just have male and female as a binary, you can't say this is what's happening to all men, this is what's happening to all women, because again, those are gender terms, not sex terms too. So like being very clear in the language, and then making a point within the methodology of doing more research, of being able to say, this is why more funding needs to go there, because we need to be able to have that disentangling that's happening, as well as just being able to have, better quality outcomes in terms of what the research is able to find and see.
then Binta, as a clinician, recording people's gender in the data, you know, do you think that that's a problem in your day job? Do you think that, you know, there's any excuse for the NHS not to be doing this?
I don't. I mean, I have very strong views in this, and I think it's not a problem. I think the problem is the lack of comfort with nuance and complexity and the need to have binaries within our systems. And that's the problem. I don't think it's a problem to have more categories and ask people how they want to be identified, right? It's not difficult as a clinician. It's not a difficult thing. And if someone chooses not to answer, that's fine as well, right? It's giving people the opportunity to share what they want. And I don't think it's a problem. I think the problem is our systems just want yes or no answers. And we can do a lot more to get more comfortable with complexity and nuance.
Grace, do you want to come in here on the data issue?
Yeah, I was going to say, I'm not a researcher, so I suppose I come from a different perspective, but I would say let communities look over research or research questions or things like that. So for example, sex workers always think of trans sex workers. So I can never think of a piece of research that's been conducted by sex workers where we've actually got male, female, because it's something that, because we are trans inclusive naturally, I suppose. So but I think it does become a massive issue, because if we miss out data and then when we go to commissioning, we end up questioning after the fact. So I was in a meeting about housing for women, and I had to ask more about trans women, and nobody had done this in the field research to begin with. That was there a need? Well, yeah, of course there was. So therefore, we then now exposing trans women to risk of discrimination? Well, yeah, we were. So therefore, that's why it's important to get it done rather than after the fact.
And do you have any, and this is for anyone, do you have any suggestions on how we can overcome this, sooner than later? I mean, we're not going to change, I was using hospital episode statistics. I don't think I'm going to be able to change tomorrow those data. Those data are still useful to be using, but is there something that we can be doing now?
So there's it's very interesting, because the research that I'm doing puts me in a unique position to kind of be in multiple different electronic health record systems. And it's not that there's an absence of the modules that are necessary to collect the data. There's kind of multiple issues that present themselves in terms of, is that included in the contract of the hospital? Could the EDI or trust or GP office or wherever just make sure that that module is implemented? It requires training at the level of either the clinicians and or the administrators of people who are going to be booking in. And really, those are kind of immediate steps that, if it's something that is part of the mission of making sure that a space is inclusive, could move fairly quickly. The bit that makes it difficult is, how many signatures do there need to be for something to happen? Is it inclusive already in the standard provision of things? And also, there's some trusts who are extremely inclusive from a standpoint of, there's questions about gender, there's questions about sexual orientation, there's questions about relationship status, but they're not considered red light questions. They're not questions that you have to answer to move through the process of the system. And sometimes ethnicity is one of those questions too. And so there's not a reliance on reporting from the person who's being booked in. And sometimes everybody becomes straight or white British or whatever that particular clinician that day feels comfortable with doing. And so it would take kind of proactive making sure that the training is there for the understanding of how, both in inclusion health spaces and then kind of other spaces as well, why that matters.
Yeah, just to add to that, I agree with that, Kate. I think it's something around changing culture and expectations of what we do in terms of data. And changing culture can seem hard, but actually at a sort of service level or local level, you can make that change in terms of what is expected and what is right. And I think having accountability and transparency in what data is collected is important. And as you say, having, you know, some EDI oversight of that, I think is something that's definitely feasible within trusts, and should be part of maybe their EDI strategy. Like, how do you actually become more inclusive? Well, be inclusive in your data systems, right?
I was going to add quickly that sometimes there's a trap in data depending on the people that you're collecting data on. So, for example, there's a statistic that says there's either 72,800 sex workers or 156,000 sex workers. Massive gap. Why is there such a big gap? And there's also statistics that say that something like 40% are Brazilian. It's not true. Sex workers advertise differently at their age, their ethnicity, but unfortunately, because there's such a lack of understanding by these researchers of the community, that they take this as gospel. And then we sex workers read these research reports, and I look at it and I'm like, you know, 80% of sex workers are absolutely not Brazilian. Do you know what I mean? Like, and or they don't realize that the data they've collected it from, it's from adult work where men can register to be a sex worker who are buying sex, but they've registered incorrectly and they can change their profile. So they've accidentally ended up included in the data. So I think sometimes working very closely with the community to understand the data, because people forget that we lie deliberately to avoid our data being collected. So, for example, in sexual health, you don't actually have to say your name and to access, and that is brilliant for sex workers who do not wish to disclose, and that has worked brilliantly, but as a result, we lie. And I think that that is often not considered in data. It's not done maliciously, it's just we're in hiding, and you end up collecting wrong data. But if you worked well with communities and understood the context of this, you could probably get more accurate data. If you asked me to go out in the community and work out the ethnicity of sex workers rather than and gender.
Yeah, and I completely agree. Just with that, Grace, just briefly to say that in addition to trying to change the systems that exist, it's about thinking about new ways of collecting information and working with communities for themselves to collect information, so it feels safe when that information is collected, and so they're able to truly share accurately. And I think we could use those different data sets to actually close those gaps in a meaningful way.
Great, thank you. Some really, really interesting insights, and I've got more questions, but I'm going to just pop to the Slido and take a few questions from the audience, and then I might come back to some of this discussion afterwards. I think this is maybe one for you, Grace. Actually, it's the top question, most liked question. Is it a problem that the majority of public health professionals are middle class and lack lived experience?
Put it bluntly, yes. I think it's part of the problem, not all of it. I do think as well that public health professionals, and some of them have admitted this to me, they work in offices where they do research and they don't actually engage with communities. It's not intentional. They go to work, they do their job, they go home. It's not done deliberately. And I think this is a trap of quite actually a lot of researchers. And I think it's true. Why would you think of these things if you're not affected by it? It's like I said in a panel this morning, I'm sick to death of reading so many articles about the drug use of sex workers and of street-based sex workers. It's like, has anybody asked sex workers what we want researching? What are the problems for our community? Where are the gaps for us? Where are the gaps for women in general? You know, when we did the Women's Inclusion Health Collective, I wrote a sort of like, why is this needed? And I did almost like a literature review of where are the massive gaps. And I had to think, these gaps exist for a reason. Now, why has nobody done research into the sexual and domestic violence rates of Gypsy Roma traveller community? And actually the data I found was estimations from frontline practitioners that was provided to Parliament. And I put my head in my hands quite often, but I think that is part of the problem, and also that communities are not given funding to deliver such research, or we're not included in the data collection itself. So it's bluntly, yes.
And if it's okay to kind of jump on that, it goes like beyond the research side of stuff too, because when you have to go through ethics, as somebody who very much, like, one, I feel lucky who I was trained by when I trained in public health, but also as somebody who very much is a feminist, from both the personal and academic sense of like lived experience is key. You can't ignore that. It has to be central. You can't take what was described and what is most common, unfortunately, a five-fingered approach to public health. It has to be community-based. It has to be kind of what we've been talking about here. And then you get into spaces where you get ethical approval. And it's not just what you want to do as a researcher, what we know is best for a community. It's also what can you then explain and defend to a board of people who then can tend to also be in that same position of lack of lived experience, very much more of a, we're going to use a utilitarian aspect of ethics and follow the status quo, and that's what makes something ethical, versus saying, which thankfully there has been more of a shift towards, we need to have the community involved. We need to make sure that they're a key part of what's happening. And sometimes it's what has to be done to get the approval for the funding, to get the approval that perpetuates the harm, when it would be possible to move quicker, because we know, either speaking with the community, an issue with my study was I was part of the community that I'm researching, and so that was a problem to the ethics committee, when it's technically should be a benefit, right? Being somebody who's queer and out about being queer, for me, is very key to say, I want my participants to know this is who's going to be handling your data. It's not going to present bias if you're a cishet participant, but I also want you to know that it's safe, kind of as a queer participant too. But you have to go through the process of being able to help to educate at all of the different stages of things, to show, no, this is really like, this is the value to this. We can't say that taking something that reinforces the status quo is somehow more ethical than looking at what's actually happening and having that discussion. And that's where that knowledge generation, which then turns into policies, which then turns into services, etc.
Grace, do you want to come back in?
Just very quickly, yes, I did, just off something that Kate just said. So I did research into homeless women's experiences of practicing rape and sexual violence services. And I self-disclosed that I was a sex worker, and it was really helpful, because I entered a room of 6 women, their backs were up, they were ready to have a go at me. One of them sat down and said, right, you know nothing about our lives. She was ready to, she felt she had to defend herself against me, because there's such a divide between the practitioner and the sex worker, and the power dynamics in that. And the moment I went, look, love, I get it, I'm a hooker as well, it's all right, I'm here with you, we both want the same thing, her back went down, she didn't defend herself. And actually I found the group were very open, left and blinded, and we had a really good discussion, more so than just research. Do you know what I mean? And I think I got more to the heart of the problem than if I asked them like a checklist. So yeah.
Yeah, and I think just just expanding on what you're both saying as well, and coming back to what Binta was saying, about the inclusion health framework, it's that lack of diversity, not only just as researchers, public health professionals, ethics boards, but for a lot of this, the funders, the commissioners, where is the diversity on the people who are making the decisions, who hold the purse strings for any of this work to really happen? And I think that's a huge problem in terms of actually getting anything done. There's recently things have really turned around, but 5 years ago, even if you tried to put in a research funding proposal saying, I'm doing co-production, I don't know what the outcome is going to be because I'm going to co-produce it with the community, they would, shut you down for not being precise about what you were actually going to deliver. And thankfully that is shifting. There's certain funders who are much more open to it than others. But I think, that's a key problem. Right, we've got loads of questions. Let's come to a couple others here. So inclusion health is a term understood in the health world, but less so outside of it. How do we advocate for these groups better outside of health systems? So outside of the health space, when we're thinking, I guess, around social services and other types of services and policies.
So this is probably what I used to do a lot. So I used to train for all the services. So I used to work with I also work with a lady who trains social services of women who've had children removed, and actually the stigma of experience for women who use drugs. I think you're right, inclusion health is very specific, very niche, and unless you know what it means, you're not, so I suppose you can either change it to people who experience severe health inequality and go down that route. But I do think it is important that we do not see healthcare as simply just the NHS healthcare. Actually, the greatest health interventions I've had in my life has actually been the third sector, or it has been just the goodwill of my own community, or mental health interventions that we've developed and things like that. But yes, I agree. I think it needs a systems change, not just a health change, because I think we're so focused on like health and hospital discharge and the diabetes rates and tuberculosis. I think actually we're not considering inclusion health groups holistically, and actually housing that they'll come in contact with, criminal justice or criminal legal system, all these sorts of areas that actually health is the one we least engage with, ironically. So
agree. I would add to that about thinking about systems and not just health. So coming back to Grace's point about the experience of violence, but taking it a step further than that and thinking about the experience of structural violence, which leads to a lot of marginalization and disadvantage, and taking that perspective, I think helps in us being able to reframe the issue not just as a health issue, but it's a societal issue, and actually we should be advocating politically around economic justice, around climate justice, around all of those other things that affect and make people vulnerable and make their health outcomes worse.
Yep, exactly. And it's the kind of thing to where I think it's in some spaces it's getting better, but I think in some ways there's a current awakening from the standpoint of making the connection between how people are treated socially and what that means. Like everything is interconnected, from a standpoint of whether or not somebody needs to be worried, to bring up the point that Grace was saying earlier, like, do I need to use a different name, or what things do I say or don't say in the space of a health appointment are going to show up in other spaces and in other ways, whether or not you're forced to use a particular ID, whether or not you maybe you have the best, most inclusive antenatal care and you're still not able to be properly registered on your child's birth certificate, right? There's situations like that to where if we don't address those, yes, there's going to be some benefits and there should always be a more inclusive health system, but it doesn't necessarily remove all the ways in which the poor health is being compounded, which is the point of an intersectional lens, right? Like if we don't advocate, there's some articles this week I was reading to where encouraging civic engagement from the American Public Health Association is seen as a public health initiative, because if you're able to be kind of make sure that groups of people are franchised and moving towards access to more equal rights and thinking about things beyond kind of fear-mongering and misinformation, that's just as much an initiative to be more inclusive from the standpoint of, again, we're here. It's not like that's not a question. Historically, like if you want to go down a rabbit hole, there's some great stories about Victorian queers, and people will be for that too. So it's being able to see kind of how we experience the world. We don't experience them one aspect of life at a time. It's experienced again in a very intersectional way, and being able to consider that is the best way to kind of approach things.
So this next question, I think, sort of builds on a lot of what we were talking about. And someone suggested, would the single biggest and most effective intervention be to tackle stigma and prejudice rather than specific concrete action?
I think it's double-edged. I think stigma and discrimination is one part of why we don't access healthcare. But I also think it's the burden of healthcare professionals and public health to be social justice, support social justice, and be advocates and be allies alongside us as well. Because I think unless you're not visible that way, we don't. For example, my biggest frustration is that we talk about HIV elimination. So United, UNAIDS, the World Health Organization have both said that the biggest impact that would eliminate HIV would be the decriminalisation of sex work. But everybody's too scared to say that because it's so political, and everyone's too scared to have that discussion that they just don't. And actually, that would aggravate me more than stigma and discrimination. So I think when we think about concrete action, yes, stigma and discrimination, I think is, I mean, we had a panel this morning where people did say that that was probably one of the biggest reasons they didn't access services. And I agree, you know, people ask me questions like, how many people have you had sex with? People assume I've got an STI. People ask inappropriate questions all the bloody time. And I'm just like, I'm just trying to get a smear love. Do you know what I mean? So I think tackling things like that are very important, but I don't think we should just stop there, if that makes sense.
Yeah, I agree. I think stigma and discrimination are what we see is the kind of outcome of all the other things that we need to actually address. So as Grace said, if we had public health and medical professionals who are advocates for decriminalisation of sex work, like that's it. It moves towards destigmatization in itself, right? So stigmatization and so discrimination and stigma, I think, are the consequence of the things that we need to be working on, not the in order to change that.
Makes sense. I'm going to sort of blast through a few more of these. Somebody would like to know, and lots of people actually would like to know, ways to get involved with the Women's Health Collective. And in the interest of time, Grace, I'm going to make you put some details into the chat towards the end, and let's keep the discussion going. Dr. Patel would love to hear your experiences on what you find in your work are the biggest barriers to accessibility for gender minorities. So we've talked a bit about stigma and discrimination. What are the other sort of main barriers to accessibility?
I would add on and say, when I worked in the violence against women sector, the biggest barrier was radical feminists or people who are openly, actively anti-trans, didn't believe in binaries. And I find that above anything else was that fear that you'd walk into a service and you expected to be treated poorly or discriminated against. That's just my quick. I'll leave more to Kate because she's more specialist in this, but from my experience, yeah.
Well, I mean, just to kind of build off of that too, making sure that there's a follow through to where it could be that your intake form is wonderful and you have all of the right things, the data is great, but then the actual administration of care, because maybe it's the admins that are more advocates and then the clinicians maybe are not so open, or you've got some people to where completely fine treatment, but then they get into places where I've heard stories of people having everything documented in their records and then having a nurse tear out their pronouns from the record and make a point of being very kind of in front of the person, like, this is ridiculous kind of thing. So exactly as Grace was saying, there's so much uncertainty, even in spaces that can sometimes feel a bit like lip service of like, oh, hey, here's a pride sign, or here's this. It doesn't guarantee that the care is going to be inclusive. So being able to kind of, going back to one of the other questions too, being somebody who's very open, very vocal as an advocate, as an ally, would be a great way to be able to have that kind of barrier there. As well as, I know a lot of people who end up doing work that's more accessible are people that end up doing more community-based work. So maybe it's not like one-on-one appointments, maybe they run a community health bit where if you just want to kind of, hey, come get something checked, don't really need your info, just need to make sure you're okay, in a space that's either housed by a queer organization or other kind of spaces where people can go, that there's different ways in which again, by talking to the community, you can find out where does it make sense to go, what is actually helpful to people.
Yeah, and I would just add as well, just to what, in response to the question, to what Grace said in terms of barriers. So there's the active sort of exclusion that Grace was talking about, but there's also that kind of passive ignorance that is a barrier because people just don't know, they don't address it. And I guess that's where our responsibility is in changing that and educating them, and initiatives like Women's Inclusion Health Collective and others, advocacy groups trying to change that, but also us as professionals being advocates.
Yeah, and I think also, you know, we're talking a lot about those sort of individual level barriers, but it's really important to think about the structural barriers as well, particularly if we're talking about inclusion health groups. You know, if you're sex working and sleeping at night, sleeping during the day, or, you know, if someone who's using drugs at different times of the day needs those sort of flexibility in appointments, you know, rules around, you know, you miss an appointment and then you can't, you know, you miss so many appointments and then you get deregistered. There's all these kind of structural factors, transport, you know, just money barrier, like, you know, all of those other kinds of things, which are really going to impact people's ability when they're, you know, particularly experiencing all of these other competing priorities and issues in their lives. You know, that sort of culture of destigmatization is really important, but also that sort of flexibility and sort of openness for people to be able to use services in a way that suits them, rather than, you know, having to conform with different sort of norms. That's definitely things that I've read about. Right, we've only got 2 minutes left. Somebody asked, can we get confirmation that our panel today is trans friendly? I think that the discussion so far should have made sure that people felt like that. How would you advise ensuring that there has been sufficient consideration of inclusion health groups and intersectionality in time-limited contexts? Yeah, so I think that question is, you know, somebody talking about sort of constraints and they haven't got a lot of time maybe to do things as sort of properly as they want to. You know, what can we do with that situation?
I mean, I think it is circling back to, I know we've talked about it before, but, and again, this is definitely more of a research-based answer, but I think it could be applicable to other levels too. It's really, if you have a limited amount of time, invest that time in the community, because that's going to be to where if you give the people within the community more time to speak, then that's where the intersectionality is going to come about. Look at the methods that you're doing. There's loads of rapid qualitative methods that you can use. There's ways in which you can move beyond kind of the binary side of stuff. Sometimes you'll have people who do advocate to where you can look at administrative data and find a note and you get a little bit more about gender diversity that's in there, or more details that are there. Also taking into consideration the fact that working with the community, if you're thinking about like a health standpoint, there's going to be an overlap, presumably, of who you can talk to within the community and who the services should be accommodating. Whether or not they're accessing them is a question you can find out through the process too. But yeah, that would be my recommendation.
Right, thanks. I just noticed the time, actually. It's gone by really quickly. It's already 1 o'clock, and apologies to people who've posted questions that I haven't had a chance to get to. I'd just really like to thank Grace and Kate and Binta for a fascinating discussion. And I hope we can keep this conversation going. It's been really, really great to connect with you all and with the audience about these issues. So thank you so much for joining us. And you know, I think overall we really, you know, got into a lot of the sort of nitty-gritties around, you know, some of these structural problems, some of the data issues, you know, some of the sort of broader concerns, and you know, working towards doing things more inclusively. So I think that's been really positive. Grace has put kindly in the chat some more information about the Women's Health Inclusion Health Collective for those who want to get involved. And thank you all for joining.
Thank you.
Thank you.
Thanks so much,
Bye.
everyone.
Bye.
Bye-bye.